So good morning, everybody. Good to be with you. I don't know if we did a poll and I missed it. Can I get a sense of who in the room are mental health clinicians? Can you show by show of hands? So the vast majority. For folks who aren't mental health clinicians, what other professions are you representing? Just shout out. Nursing. And I know we have the legal system. Yeah.
Early childhood.
Early childhood. Physical therapy. Okay. Social work. Okay. Well, this information is going to be somewhat geared towards the mental health clinician, but for folks who are here from other professions, please, hopefully there'll be things to glean, and please jump in and ask if, I'm using shorthand for the clinicians in the room, and if we can try to adapt or apply anything to your work that we're covering. So we're going to be talking about relationship-based assessment with infants and their caregivers, and Michelle is absolutely right in terms of kind of introducing this topic. I think it's actually really good the way she structured the day, because as mental health clinicians, we know that the first step in a good treatment and in good intervention is to do a good assessment of our clients, and so my esteemed colleagues this afternoon are going to be going through several different treatment approaches, and I think all of them would agree that leading into treatment, we need to first do an assessment of where the child and the family is at to know what they're going to need out of treatment. So that's kind of where we're starting, is in the assessment phase of things. And when we're thinking about young children and infants, in an assessment, we're really thinking about a relationship-based form of assessment. And the reason that is, why are we talking about a relational assessment? Is because the relationship is really, for this age group, the most central and important factor in their well-being and in their mental health. You see this quote here by Winnicott, an old psychoanalytic theorist. There's no such thing as a baby, and the idea there is that you cannot. A baby is not a independently functioning individual. That their sense of self and again their well-being, their experience is interwoven with their caregiver and that attachment relationship. And so you can't really get an understanding and a picture of what an infant needs without understanding their relationship to their caregiver. We know from research that the caregiver-infant relationship affects all domains of development. This isn't just a psychological phenomenon, but the relationship quality affects motor development, it affects speech-language development, cognitive development. So for those in the room who are from other professions, the relationship is of central importance to you all as well in the work that you do. In addition to that, the caregiver-infant relationship can really serve as a buffer against other kinds of risk factors that the infant may experience, whether that's prematurity or poverty or exposure to trauma. We know that the quality of the parent-child relationship, if there's a security there in that relationship, that can actually buffer against the impact of some of those risk factors. Or unfortunately, if the relationship is an additional source of stress, it can intensify the impact of those stressors like trauma and poverty, etc. So it's just, it's universal in terms of its relevance for young children and how we understand their functioning to understand this attachment and relationship with their caregiver. So just a few kind of underlying principles about caregiver-infant relationships, and many of you will know this from your child development courses and your theory courses back from graduate school, but of course attachment is a biologically driven a phenomenon. There's plenty of science now, very advanced science that has shown us all the ways that mothers and caregivers and babies physiologically are primed to create this attachment relationship. So there's a very inherent or intrinsic quality to the infant caregiver relationship. These relationships are also transactional. Does anyone familiar with that term or have a sense of what that means? Can someone throw out a definition for me?
Give and take. Goes back and forth.
It's a give and take. It's a back and forth. It's an interchange. Exactly. So it's not simply the behaviors that a parent kind of acts towards the infant. It's not simply the infant's temperament, but it's how the two interchange in the space between them. What happens when you bring together this caregiver and all of their individual characteristics and this baby and all their individual characteristics, and what happens between them. And those moment-to-moment interactions, those transactions, are what really drive development. Those are kind of the sparks for developmental progress. So that's just another important kind of theoretical concept when we're thinking about relationships. Caregiver-child relationships are also largely influenced by internal working models. Are folks also familiar with that term or concept? Yeah. So an internal working model is something we think about for adults. And for those who aren't familiar with the concept, it is essentially the template for how you understand and perceive and interact in relationships in the world. And that template is created in your early childhood experiences and attachment with your caregiver. So the qualities that you experience as a baby and young child with your caregiving figure create perceptions and beliefs about relationships in the world and whether people are trustworthy and safe that we know carry over across development and into adulthood. And that adults have this template that is a filter through which they understand relationships and see the world. And so naturally it's impacting all their relationships, whether romantic or social or at work, but it's also affecting their relationship with their baby. And so that's going to be really important when we think about some of our assessment methods, because trying to get inside a parent's beliefs about relationships, and in particular their beliefs about their relationships with their babies, is going to be really important for understanding how that relationship works. And then these moments of synchrony and asynchrony, basically this is the idea of attunement, is maybe a term that's familiar to you all, that these transactions that are occurring, they are moment-to-moment interactions. We saw them in videos that Dr. Graham was showing of caregivers and babies interacting where a baby coos, and then the caregiver smiles, and then there's an exchange that continues between the two of them. And when that's happening in a smooth and fluid way, those are moments of synchrony where the caregiver is accurately picking up on the cues that the baby's giving, that the baby's happy or the baby's distressed and needs something. And when there's a mismatch and the caregiver's kind of missing the cues that the baby's giving, those are the moments of asynchrony. And those are going to be important. Those are also going to be important concepts and things that we're looking for in our assessment of the relationship once we get to talking about what these assessment methods actually look like. Because we want to see how do these caregivers attune to their babies. Are they picking up their cues in a sensitive manner, in an accurate manner? And when there are moments of asynchrony, because there inevitably are, like it's not bad to have these moments of disruption where a caregiver and baby are out of sync, but when those do occur, is the caregiver able to understand that, to recognize that, and to make a repair, and to get back online with their baby and respond in the way the baby needs? And actually repairs are just as important as the synchrony. because it's important for children to learn that even if mistakes happen and my parent doesn't read me perfectly, they're going to work hard to understand what I do need and get back on track with me. So, any questions about any of those concepts? Okay. So when we're thinking about doing an assessment, a relationship-based assessment, I think the first natural question is, well, what does that involve? What are we actually assessing? So before I put up my ideas of what that kind of assessment involves, what do you all think? If you were going to assess a relationship between a baby and a caregiver, what would you want to look at?
Attachment.
Attachment, okay. And how specifically would you look at attachment?
Like at handoffs, like if the baby is secure or insecure. So through observation.
Observations of the baby and the caregiver together? Yeah, and specifically I think you mentioned like a handoff, like how this baby does adjusting to other adults or other caregiving figures. Yeah. Good. What else? Did you have something else, or were you just saying?
Just said through observation.
The observations. Mm-hmm. What else?
How the parent responds to distress in the child.
Yeah, how the parent responds to distress. Absolutely.
Did you say eye contact?
Eye contact.
Flat out, just eye contact.
Absolutely. Yep.
I think too, like obtaining a baseline, if you are doing any type of observation, and you look at the baseline of where they were at and see if it's improving, decreasing. Or
Yeah. Yeah. So that's a good point about assessment, and we'll kind of get to that towards the end. Like, how do we use the information we get out of an assessment? You can use it to track progress in treatment. So how do these interactions look at the beginning before I start with my intervention, and how do they look, 3 months in? Or at the end of treatment. Great point. You all are picking. This is great because you're all mentioning kind of observational approaches to assessing the relationship, which is great because I don't think a lot of times clinicians don't think in that way. In addition to observations, what else might you want? What other kind of information would you want to gather to understand the relationship? History. History. What kind of history?
Any type of history of their interactions or any type of trauma.
Good. Trauma history. Yep.
Family history and the makeup of the family.
Very important. Family history. Yep. Absolutely.
Prenatal.
So developmental history. Yeah. Knowing about the infant's own individual kind of history developmentally. Yep.
Parental attitudes.
Parental attitudes. Yep. So getting inside that caregiver's head a bit, understanding how they view and perceive parenting.
Would want to know what the support network is.
What the support network is, yeah, absolutely. Yes, and you all are hitting on, I think, all of the ones I have here. So we do want to assess and take a look at that child's individual functioning, things like their own development, their temperament. We want to know what that baby is like in an individual way. Because going back to that concept of the transactional nature of the relationship, the baby's going to bring some inherent qualities, that's just who they are, to the transactions. Babies with fussy temperaments bring that fussy temperament into the relationship with their caregiver, and that affects the transaction that occurs. So we do want to, even though our assessment is relationship focused in orientation, we still want to know something about that baby as an individual and what they're bringing to the relationship. Likewise, we want to know about the caregiver's individual qualities and what they're like as an individual. So their intellectual ability, that's really important to thinking about parenting, is what kind of development the caregivers had and where they're at cognitively. Psychological domains. So are there psychiatric or substance abuse concerns? We also want to be looking at those kinds of things because, again, those qualities of who that caregiver is as an individual are going to be things that they bring to the transaction that are going to affect that to and fro. It's going to come into play as the baby and the caregiver interact. We also want to, someone mentioned family history, we also want to understand the family history, and specifically as we're thinking about these types of assessments, I think the intergenerational history of trauma is particularly important because we know, and Dr. Graham was talking about this, we know that that trauma experiences get passed along through generations, and that when a caregiver has had trauma experiences in their own early childhood, that is going to impact their perceptions of relationships between babies and children, right? So their filters are going to be shaded by how they experience their attachment relationship, and that there's going to be a particular shade to that if there was trauma in that relationship. So we need to understand what kind of experiences the parent has had in their own background. And then the caregiver's perception of the child and their relationship with the child. It was mentioned as attitudes. We're going to talk about it here kind of as beliefs and perceptions. But we really want to try and get inside the head of the caregiver, and not in an intrusive way. That expression sounds kind of very psychologist of me. But to understand the perceptions of what that caregiver has about their baby and the relationship. And with this area in particular, we're going to discuss a specific tool, an interview tool that gets at these types of perceptions. So we'll cover what that might look like. And then you all were touching on this right away. We definitely want to assess through observation. We want to see this baby and their caregiver together and what that's like. Absolutely critical. You can't do, in my opinion, you can't do a good relationship-based assessment without seeing the child and the caregiver together. And we're going to also talk about a specific tool that you can use to structure your observations of the caregiver and the child. So how do we want to go about doing this assessment? All of the clinicians in the room will probably be familiar with taking a kind of multi-method approach to our assessment, right? We don't ever want to rely on any one single form of assessment data. We want to collect information from across various different tools and domains. This is what I'm presenting here is kind of the ideal, in an ideal world, how this assessment, how you would do it. Of course, I know there are limitations to resources, time, but I'm going to present to you what I think is the gold standard of creating and collecting this kind of information, creating this kind of assessment, recognizing that there may be limitations to how much of this you can do for every case. But one of our methods would be to do an interview with the caregiver, actually to do a few different types of interviews with the caregivers, to talk about, again, to get an appraisal of their own individual functioning, to get a good developmental history of their baby, but then also to do an interview around those perceptions about the relationship. And we're going to break that down a little more in a bit. We can also get caregiver reports through questionnaires. I'm not going to focus on this as much in the presentation, but there are a lot of paper pencil kind of forms that caregivers fill out that ask them about their relationship with their baby. The parenting stress index is one that's commonly. Anyone use the PSI, the parenting stress index? Are familiar with that? That's the one I've most commonly used. That's not, again, I'm not going to focus too much on those things in this presentation, but if you're interested afterwards, we can talk more about paper measures. And then, again, observation is going to be key because young children, are largely nonverbal, particularly if we're thinking of 0 to 3. And certainly, even when they develop language, may not be able to tell us about their internal experiences like an older child would. That means that observation is going to be a huge and key source of information for us about about them and how they're thinking and feeling. Observing behavior is really the keystone of doing early childhood assessment. So that's going to be a very, very important method. And we want to observe them just kind of individually. Again, we want to get a sense of who this child is, what they're bringing to the relationship in an individual level. So spending some time in play, that tells you a lot about their development, their motor development, their cognitive development. It may tell you about trauma history, if there's trauma-themed play. It tells you about some kind of their social skills or their social relating with you. But of course, as we've already been talking about a lot, we want to observe them interacting with their caregiver as well. And then collateral information of any kind that may be pertinent to the case. So in this first type of interview, which I think is probably the one that most of you all are more familiar with, and this is the type of interview where you're really trying to get an appraisal of, who this parent is as an individual, what their baby's like, what their baby's development has been, what their baby's behavior is, asking about the family history. I think that's the type of interview that many of us are initially trained in as clinicians. So we are going to ask about all these areas like their development in motor, language skills, about their behavior. We may do kind of a symptom, checklist kind of type interview. This is going to be your more standard type of mental health approach to doing an assessment interview. Likewise, with the caregiver, you'll want to ask them about their own experiences in terms of mental health issues, substance abuse, their relationships, their employment. Again, the kind of information you would gather maybe doing an intake for an adult client that you were seeing. Something that I think we're pretty familiar with doing. And then the family history, and specifically, I think a lot of times we're initially trained to talk about family history in terms of family history of mental illness. Is there a history of depression or a history of, some other kind of psychiatric condition, which is really important to ask about. But I would argue in this type of assessment, even more important is to ask about the family history of trauma. Because again, that is going to play such an important part in shaping this caregiver's perceptions of their relationship with their baby. Mindy is going to talk more this afternoon about CPP, and there's this concept of ghosts in the nurseries and angels in the nursery. Anyone heard of ghosts in the nursery? Yeah, so that's a real classic in the infant mental health world. But it's this idea that that caregivers bring their own early childhood experiences. Again, they have this template formed in terms of relationships and safety in the world and trust, and that they bring that into their current interactions with their baby. That those ghosts, whether it's trauma or a disrupted attachment of some kind, those ghosts from their own past come into play with their moment-to-moment interactions with their child. And then Alicia Lieberman and Patricia Van Horn, who Mindy will talk about this afternoon, who developed CPP, they added angels because it's not only ghosts from a parent's past that influence their relationship with their babies, but it can also be protective people, relatives who stepped in when that child was in danger or when the situation was perilous, and who were a protective force in their life. So all the relationships, the important, significant relationships in a parent's history, we want to try and understand because, again, those relationships created the template for how they're going to approach their relationship with their baby. Yeah.
This is like putting you on the spot, but kind of backing up, I'm thinking about how difficult sometimes it is to engage parents in an interview with older kids. Like they want you to only ask about the kid, not about them.
Yeah.
Could you kind of talk about, or just how do you engage the parent in this idea that it is this broad view, it's not just about the baby? How do you get them to engage to give you this kind of?
Yeah, that's a great question, because it's a shift for a lot of us who were trained more, when working with older children and in models where we focus on the children more. So, I mean, I think one way that's maybe a non-threatening or strengths-based way to kind of approach it is, explaining to caregivers that, you're the most important person in this baby's life. Explaining kind of what I did in the very beginning. The rationale here is that your baby's well-being is totally dependent on their relationship with you. And so you are an incredibly important piece to understanding how to help your baby feel better or do better. And so part of that means me really getting to know you better, because the two of you are going to be working together, because I know you want your baby to feel better and do better. And so kind of approaching it as, in a strengths-based way, emphasizing how central they are. That's my initial thought on how I would go about that. I don't know, others have thoughts about how you would approach that?
I think it's important to recognize that your client is not actually just a child.
Yeah.
It's now in more of a family setting.
Yep.
So your client is this family.
Yes.
So making sure that you approach it that way first, and then your ultimate goal, and then staying and maintaining on that positive track of why you're needing to obtain that information, like you were saying.
Mm-hmm. Yeah, and setting that, I think setting the stage from the beginning is what I'm hearing from you, is like, it's always the expectation, you're not taking the child back to your office separate from the caregiver. I mean, you shouldn't do that with a young child. And that should be, the approach should always be from the beginning. It's something as simple as always bringing in the caregiver and the young child together. And that symbolically, demonstrates for the parent like this is about them too. And it requires you to, I'm learning this more, I'm relearning this again and again. In infant mental health, you are really using a lot of your adult clinical skills, a lot. You have to know your adult psychopathology. You have to know your, psychotherapy methods for engaging adults, motivational interviewing, some of those more adult-focused theories and models, because you're doing so much work with the caregivers. Does that answer your question, Michelle? Mindy, I know you do a ton of this work. Do you have any other thoughts? Okay. So, any other questions before we move on? So, I want to spend a little time talking about some specific tools for doing these relationship-based assessments. And I'll preface this by saying that this is going to be an overview of these two tools. There's really in-depth training available for being able to administer them. So I in no way will be able to certify you or bless you as clinicians I don't have that authority. But I do have resources at the end of this slideshow if you're interested in getting the more in-depth training, where you can go and check it out, because they're really helpful methods or tools, I think. So the first one is an interview approach, and this interview I was talking earlier about. Not only do we want to get a sense of kind of individual, who this parent is as an individual, who the baby is, but we want to try and get inside that caregiver's experience of their relationship with this baby and their perceptions about the relationship and how we might be seeing their own history kind of expressing itself in how they talk about their baby. And that is done through the working model of the child interview. Anyone heard of this interview before? Great. So this is new for everybody. That's exciting. So really what this interview does is it provides, again, a window into the caregiver's perception of their relationship with the child. And it does that by trying to elicit a narrative about who this child is from the caregiver's point of view and what their relationship is like through the caregiver's point of view. It's a semi-structured interview. So the questions are clearly laid out in front of you, but there is some leeway to ask follow-up as you go through the interview. But it is there is a fair degree of structure to it, and in fact, it is ordered in such a way that it goes from like some emotional intensity to a lot, by the end of it, a lot of emotional intensity. So early on, you're talking about the prenatal history, what it was like when mom was pregnant, what the first days of parenthood were like, and then towards the end, you're asking about things like the parents' perceptions of setbacks their child has had, what that child is going to be like in the future, do they think? What are some of their fears and worries about their child? So some very emotionally kind of evocative stuff about thinking about their child's future. So there's a gradual progression to it, and it's important to stick with the structure of the interview because it's designed that way to gradually move the caregiver deeper and deeper into their perceptions about their child. So it asks about their development, personality, and behavior, but all of these things, different from the interview I was describing before, all of these things are asked about in connection to the caregiver's relationship with the baby. So for example, in asking about behavior, in this interview, we're not asking the caregiver about how many times a day their 2-year-old has tantrums and what they do when they have tantrums. Do they throw toys? Do they bite? Do they scream? Here, when we're asking about behavior, we're asking which of your child's behaviors are the most difficult for you to handle. So you see how there's a relational kind of slant to that question. So that's really the tone of this interview. So even though some of these things we talk about in other ways in our more traditional interview, here they have this kind of more relational focus. And you do this with one caregiver about one child at a time. So here are some example questions from the working model of the child interview. It takes about 45 minutes. In theory, it takes about 45 minutes to conduct, but I've had it take much longer because there's a lot of intense questions and it opens up a lot. But here's just a sample of some of the questions. So tell me about your labor and delivery. What was your first reaction when you saw your baby? How did you choose your baby's name? That's one of my favorite questions. I think that is so. For some of you, there's a projective quality to this interview, and everyone familiar with like projective testing or projective, forms of assessment. Anyone not familiar with that concept? Okay, so there's a projective quality here where you're asking somewhat ambiguous or neutral things, and you're trying, but prompts that will pull out some emotional content. Who does your child remind you of? Your favorite story about your child. The 5 adjectives to describe who your child is. What do you expect your child to be like as an adult, as an adolescent? And I have heard so many interesting descriptions of children through this interview. And what you end up doing is interpreting and scoring the interview. And I'll talk about a few examples of interviews I've done that come out as balanced, disengaged, or distorted. These are the ways that they're classified at the end of the interview. But first I'll go through the actual features. So you're looking for richness of detail. So how much, when you ask, tell me 5 adjectives to describe your child's personality, and then you ask them to, after they've given you the 5, you ask them to say, okay, so you told me that your child is rambunctious. Give me an example of, what that looks like. And so you're looking for richness of detail. Like, do they really paint a picture for you of what that looks like in their child? Do they convey an openness to change? So are they curious about their child? Do they have a sense of wonder? Like, early childhood is a time of rapid development. Things are changing day to day. in this baby and young child, and so are they anticipatory about their child's personality, what they might become, what their behavior means. Is there an emotional intensity? So one of the things that you're doing during the working model is you're not only paying attention to the content of what they're responding, but you are paying attention to their emotional presentation. So I have had interviews with caregivers where you're asking these questions that have a very emotional charge. Again, they have a projective kind of quality to them, and the caregiver is completely flat in their affect. And that gives you a sense of what their experience of what their baby is like when they're talking about their baby who is growing and changing and developing and exhibiting all sorts of behaviors, and there's a flatness there. You want to pay attention to that as well. It's not just about the content. Is there sensitivity, and is there an acceptance of who their baby is for that baby as an individual? You can score them as balanced, disengaged, or distorted. I'll give you a few examples of interviews I've done. So disengaged, I had a caregiver once who I did an interview with, and she was one of these caregivers who was completely flat the entire time. I was talking with her about her baby, and she had a real paucity of detail in her account. So when I asked her to tell me about her child, give me 5 adjectives to describe your child's personality, she said something like happy. And then when I did the follow-up, okay, so you told me your child is happy. Give me an example of that. She said, well, he likes to play. And that was it. So there's not detail there. There's not an involvement in understanding her baby and who he is and what he's like. That's an example of kind of a disengaged presentation, that flatness combined with the lack of detail. This mom was very disconnected from her child. She didn't know him. Distorted is where as it sounds, there's usually some kind of distorted, inconsistent, odd quality to the descriptions. A lot of times I found this to look like a very self-involved parent. So for example, I had a parent when I was doing this interview, she described this was, I think, I want to say a 2-year-old child between 2 and 3, a little girl. And this girl was out of her mother's care. She was in custody. This mom described this little girl as Little Miss Hot Stuff. And she's just like her mom. She's wild and crazy. She likes to dress up in my stiletto heels. When I asked her what she thought the greatest setback for her child would be, she said, well, if I don't get her back soon, she's going to forget who I am. So you see how that's a very distorted perception of her child. That child is fulfilling emotional needs for her. There's this mirroring need, she's just like me, wild and crazy, a little bit of a sexualizing element to it. She likes to wear stiletto heels. And also just meeting the emotional need of, not being able to recognize that being removed from her is an extremely traumatic thing for this young child, more focused on her needs, that she not be forgotten. So those are the kinds of things that this interview pulls for and that you're looking for as you ask the questions from caregivers. Let me pause there. Any questions about the working model?
Mm-hmm. I'm kind of curious about the inter-rater reliability of something like this. And so do you end up with the result of balance, disengaged, or distorted, or is that like a continuum? And if so, do raters, are they consistent?
There is inter-rater reliability. So that's a good question, because you can use this interview a few different ways. You can use it more qualitatively, where you give the interview questions and then you just kind of clinically use your own interpretation of some of the things you hear about this child's or about this parent's perceptions. But if you are going to do the actual scoring, you have to go through more formal training, and to do the actual scoring, there's not I wouldn't say there's a wealth of research on the measure, but there is some measure suggesting that it's reliable. Yeah, Mindy?
I was going to say, for all the different kind of use it, they all use it clinically. I've only seen it really, and you might know differently, but
Yeah.
it's usually scored mainly for research.
Yeah. Yeah, it's very often used clinically, yeah.
And so is it given like in the baby course at the beginning and at the end?
Mhm.
And then it's just kind of a clinical observations, like, gosh, she's a lot more engaged, second time around.
I've actually used this where I videotape the interview with the mom or dad, and this is not how you have to do it, or it's not a part of the formal implementation of this interview, but videotape the interview and watch it with the caregiver in the next session early in treatment, and it actually can serve as an intervention for them to watch how they talked about their baby. And it's amazing the insights that they will come to, the interpretations you made in formulating the interview, and they'll come to a lot of the same insights about how they talk about their baby.
Would that be considered like a narrative type of therapy?
There's definitely a narrative quality to it, yeah, absolutely. There's definitely a narrative quality to it. And at the end, likewise, at the end you can reflect with the caregiver on, gosh, look at how you're able to describe your baby now. Look at how much you've learned about your relationship with your baby. So I find the videotaping really helpful. Yeah, Mindy?
One other thing in baby court, so there are a couple of questions that I really like if you could do anything differently. If there's something you can change, what would you change? And you have a lot of parents who have a child in foster care and they say, oh, I wouldn't change anything.
Yeah.
That's a pretty big red flag. And certainly by the end, you've got a much more open and they're able to talk about the differences. So yeah, I don't think that necessarily needs to be included. That's a pretty good place to be.
Any other questions about the working model?
What's the age range that's typically used?
That's a good question. It was developed for use with young children. 0 to 5, I think, is the original age range. But I've actually used it clinically with older kids. You can use it for kids into their adolescence clinically. Now, again, like Mindy's saying, there's a research focus where you do kind of the more formal protocol with it. The questions are very powerful, even to ask about older kids. Any other questions about the working model? So you often see, in the infant mental health world, you will often see the working model interview being paired with the Kroll, the Modified Parent-Child Relationship Assessment. This is an observational technique, and you'll see that as kind of a standard battery along with the other interviewing and information we're gathering. You'll often see the working model and the Kroll paired together as a workup for dyadic caregiver-infant therapy. And so the Kroll is an observational tool to observe parent-child interactions. It is a standardized set of tasks that are both structured and structured. There's a variety of things that you do that have both a structured and unstructured quality. This is designed for children ages 1 to 5. You can't really you can't technically do it very well with children under the age of 1 because of some of the tasks involved, and we'll see that in a minute. It's also administered with one caregiver at a time, and this also, even more so than the working model, videotaping the Kroll is, I would say, almost essential. I don't think it's ever been written or described as required to do as a part of the procedure, but so much happens in these moment-to-moment exchanges between the caregiver and an infant that it's really helpful to have video playback. And this is also, you can also observe, in the therapeutic process, you can also observe video with parent and reflect with them on what they see in their interactions with their baby. So what do we do in the Kroll? So these are the stages of the Kroll. You start out by having free play, It's totally unstructured. And the way this works, I'll back up. The way it works is you have the playroom set up with the parent and the baby to be in. And then from behind a one-way mirror, you have the clinician who's observing. The clinician's not in the room. The ideal setup is for there to be a phone in each room, and you call in. That's kind of the classic arrangement. You call into the parent and move them through these stages of the procedure. So you get the caregiver and child set up in the room, and they do free play, totally unstructured. You just tell the caregiver to spend some time playing with your child, and you observe how that goes. You then call in and you have them do cleanup. And after they do cleanup, you have them play bubbles for a minute. You instruct the caregiver to blow bubbles for the baby. And then you do a series of more like teaching tasks. So you have a few, maybe 2 to 4 bins. In each bin, you have kind of a more challenging or teaching type task, like a puzzle, cubes, shape fitting, threading the beads through string, and you want to pick a few different tasks and some that go beyond that child's developmental ability. So you want to pick a task or two that are harder than a child that age would probably be able to do, because you want to introduce a teaching element and see how the parent does teaching and managing stress with the baby. And then after that you do a separation and reunion, which of course is out of the strain situation with Mary Ainsworth. So you have the caregiver exit the room for 1 minute. You let them know that you're going to be watching the baby, and they stand right outside the door. And then after a minute, you ask them to go back in, and you see what happens. So that's kind of what you do. Any questions about that, the procedure?
How long does the whole thing take, like this whole part?
Less than half an hour. It's not very long. I think you spend about 5 to 10 minutes in free play. Cleanup, doesn't take very long. A minute with bubbles, and then about 3 minutes with each teaching task. The separation and reunion is a minute each, and then you wrap up. So it's fairly brief. So, like I said, this procedure provides you with an extremely vast amount of information. You see so much about how this caregiver and child interact together. So the types of things you're looking for, and this is not an exhaustive list of what you would be looking for, but you particularly want to pay attention to nonverbals. It's not about what the caregiver and the baby are talking about. It's not content focused. I think a lot of times in our interviews and our clinical methods, we are very content focused. This is process focused. What are they doing together? What are the nonverbals? What's the emotional tone? So things like proximity, like how close are they together? Is there physical touch? What's the energy like? I have observed caregivers who don't move, who literally sit still while they have a young child who's very active and moving and wanting to play. Is there eye contact? Someone mentioned eye contact at the very beginning. What are the facial expressions like? Are they looking at each other, and are they sharing mutual enjoyment through smiling at one another? These are the types of things you're looking for. Are they talking? It's not so much what they're talking about, but is there vocalization? Is there connecting through verbal communication? I've had crolls where the caregiver and the child are almost silent the whole time. I think one of the most dramatic crolls I ever saw was it was a little boy. He was just shy of 2 years old. I think he was maybe around 20 months, and he was out of custody. He was in care, and I did a croll with him and his dad. His dad had been the perpetrator of domestic violence in the home, And so we did a crawl with this little boy and his dad, and this little boy, the dad kind of sat in the middle and made it in the middle of the floor in the room and made attempts to invite his boy over to play with toys. But this little boy started off running around the perimeter of the room in circles. Then he went to the corner and turned his back against his dad, played with a toy. Then he started throwing toys at his dad. And then he started kind of laughing in this very dysregulated way, kind of hysterical way. So his behavior was completely erratic. I'm not able to, and the dad all the while is, calling his name, trying to get him to come sit next to him and play with a truck or something. But this little boy not able to engage in a, developmentally appropriate play with his father at all. So very disorganized. You see so much in these observations. You also want to look at the response to stress. They intentionally have stress-inducing activities embedded into this observation for a reason. You want to see how the caregiver and the child navigate something that stresses the child a little bit. Obviously, we're not trying to create traumatic experiences for the child, but you want to see cleanup. You want to see them trying to do a task that's a little hard for them. And of course, the most stressful, or in theory, the most stressful event is the separation. And so you want to see what the child's response to that is like, what happens when the parent comes back in the room. Of course, we know from the strange situation, it's not so much how the child responds when the parent leaves, it's what happens when the parent comes back in. And do they seek to reconnect? I've seen children who avoid, who don't even acknowledge that their parent's back in the room, who are distressed and dysregulated and can't become calm. So you see all sorts of things, and you're really looking to see what is the reaction when the parent comes back in. Yeah?
Have you ever had to end the separation part early because of traumatic experiences?
Yeah, good question. There have been a few occasions where a child has become so dysregulated by the separation that we did end it early. And not because I thought that separation was traumatic for them, but clearly it was triggering things that were just too overwhelming for this child, and we felt like it was not appropriate to put them through that. There have been a few times. But you do not end it just because a child begins to show some level of being upset. If they start to cry, or if they go to the door and try to open the door. There's some clinical judgment involved with that as to when you think it really crosses the line and becomes, the child becomes just too overwhelmed. Yeah.
To piggyback on Laura's question, you described somebody very familiar whenever you're talking about those interactions. What do you do in that case? If you do have to end that separation part early, do you do slow exposure, or do you just go away with it, or what is the process if they are acting that way due to the exposure?
So how would we reintroduce the parent if the that's a great question, because you want to manage that therapeutically at that point, because it's the child's just extremely overwhelmed. So I would the way I've done it is, and usually the parent's overwhelmed too, because they can hear their child really upset, and so you want to attend to both of their emotional experiences, and so I have approached parents who are waiting in the hall, and I say, I don't tell them that we're ending it early. They know that they're going to be ending it in a minute, and they don't have their stopwatch out, So I just say, well, let's go back in, and we can hear that so-and-so is really upset. And then I sit, I go in with them, so it's not simply reintroducing the parent by themselves. I go in with them, using all my good soft therapy talking voice and all of that, try to spend some time with the caregiver and child to help them reconnect, maybe get on the floor with them and play a little bit, reflect if the baby goes for a hug, just reflect on what the baby's telling the caregiver. Try to make that more of a therapeutic wrap it up in a more therapeutic way. And even ask the caregiver, what was that like for you? Is this something that happens at home, or is this kind of a new experience for you? So just kind of processing it a little bit is how I've approached it. Good question. Any other questions? Mindy, any other thought? You have had experiences with that?
I think for the parole, as long as it's an actual separation where the parents leave the room, I don't think, as long as they come back and you can see how they unite, I don't think it really interferes with it. Try to do it for at least 30 seconds.
Mm-hmm.
And, a lot of babies, if you've got a 9-month-old to a 12-month-old, they should cry. Not necessarily if they're in daycare, but the crying is okay. I would worry, how the caregivers deal with it and what their meaning behind the baby's crying.
Yeah, good point. So the children you do this on the younger end of who you'd be doing this with, there should be some developmentally appropriateness to that. Yeah.
When the mother called out to leave the room, do you observe how she leaves the room? Does she leave immediately? Or do you observe how she interacts with the child?
Yeah.
Maybe back
Yeah.
play with this? Or is there certain things that you look for in that? Or do they have to leave immediately?
Yeah, great question. So you do want to look at, the reunion is the most important piece, but you want to look at, does this caregiver emotionally prepare their young child for the separation? Do they say, okay, explain it to the child. I have to step out and go. A lot of them will say I have to go to the bathroom. That's like classic. I have to step out and go to the bathroom. You wait right here. I'll be right back. Give a little kiss on the hand or the cheek. Do something nurturing and to prepare the child. That's what you'd love to see. But I've seen a lot of caregivers just leave the room and not say anything to their babies, which tells you a lot. So, great question. Yeah, you definitely want to look at how that transaction happens. These are great questions. Any others?
You
Yeah.
are assessing the caregiver-child relationship.
Yeah.
Have you already assessed those individual variables like intellectual ability?
Right.
History of
Yeah.
all of the pathological possibilities, psychosis, whatever.
Yeah.
Do you already have that information?
Yeah, that's a great question. So kind of the ordering of how this happens. I would typically have done my initial interview, kind of that groundwork information gathering, prior to doing the working model and the crawl, because that really is foundational. There are considerations there that you might want to tweak your methods a bit depending on some more extreme type situations you might be dealing with, whether it's a parent who's been psychotic or has an intellectual disability. So yeah, I think you'd want to have some of that information prior to these other methods. Great question. So these are the things you're looking at in the observations. Does the caregiver respond sensitively to the cues? Is there comfort in the diet? I've kind of given you some examples of how I've seen this play out. It's not so much about compliance. I mean, you certainly want to look for, there's some element of looking for can this caregiver give some instructions and that the young child follows. But I think the overall focus of the CROL is more on the emotional quality of the relationship and not so much the behavioral effectiveness of the caregiver. Does that make sense? So you're really looking for more of those the relational and emotional qualities. But there are other observational methods out there, and the CROL is not the only one. Here are a few others. The still face, which you can use with much younger children. The CROL becomes challenging. Those learning tasks are obviously a little more challenging to adapt down to a very, very young child and infant. So some of the things in the CROL are not as developmentally appropriate for a very, very young child. But the still face is one way to look at the relationship between a young infant and their caregiver. And I think Dr. Graham showed some of that earlier. This afternoon, Dr. Abner is going to talk about PCIT. They have their own method for doing an assessment of the caregiver-child relationship at the start of PCIT. Some of you maybe even do PCIT, so you know the DPICs. is a part of that. The Marshak is another one. Anyone heard of the Marshak interaction method? It's another one that's commonly out there. And the Marshak, I think, fairly closely resembles the Kroll. It's a lot of similar components. So kind of wrapping things up here and talking about these assessments, what do we do with the results? Well, of course, we want to integrate all our results together. We did a multi-method approach, so we want to integrate everything we know from the working model to the Kroll to the information about the intergenerational trauma, etc. You want to focus on areas of challenge and strength in the relationship. I think a really important thing is not to pathologize relationships because these relationships, no matter how challenged they are incredibly important in this young child's life. Again, it's like it's intricately connected to the child's well-being, and so we don't want to use language and communicate our findings in a way that disparages these relationships, but more talks about the challenges that need to be addressed in the relationship. You want to acknowledge the limitations of doing it in a clinic-based procedure. You know, we're not in the home, we're not living with these dyads 24 hours a day, so there are limitations to just this snapshot in time, of course. This isn't really these aren't really methods to actually assess the attachment type. You know, insecure attachment versus secure, and the insecure, ambivalent, avoidant, and disorganized. So we're not really doing that. We're not coming out of this with a diagnosis. We're not diagnosing RAD out of this. We're not really diagnosing any other kind of mental health condition. So it's a different kind of assessment in that way. You're really describing what you saw about this relationship and ultimately what the dyad needs in terms of treatment. These are really treatment-focused assessments. What do we need to provide them? And if we're doing a relationship-based assessment, we obviously want to connect this to relational interventions, which is the segue into this afternoon. Things like child-parent psychotherapy, circle of security, PCIT, which we're going to talk about as well. Mom power will be talked about, and other relationship interventions. So we just want to connect the relationship assessment with an actual relationship intervention. And then I recently added this slide because I often get asked, what's the difference between this and a parenting assessment, a quote-unquote parenting assessment? And I would say in theory, there's not a difference. But in practice, the way I've seen parenting assessments done, I think there are some key differences. And Mindy and I were just talking about this right before I came on, kind of the debate around this. But the way I've seen parenting assessments done a lot of times is they're just done with the parent. They're interviews with the parents. And they give the parents questionnaires that assess for their knowledge about child development, for their attitudes about parenting, for their, the kinds of behaviors they use in their parenting or discipline methods. So hopefully what you've seen me describe here today is obviously very different than that. And these type of relational assessments, you always are doing them with the caregiver and the child together. While there may be elements of learning about that caregiver's knowledge of child development, you may want to know about some of their parenting behaviors. It's much more about observing the actual experience of this relationship and assessing the emotional qualities of the relationship. So I think those are the key differences for me. Something else is that I really see these relationship-based assessments as being, again, treatment-focused. This is about guiding what kind of work needs to be done in therapy to address these challenges in the relationship. These are not, I have not used them to be prescriptive about custody arrangements. Now, they do get used in infant court. Is that the point you were going to make?
But if you see somebody recommending custody without doing something like this, that's a big problem.
Good point. So if we were going to make prescriptive custody recommendations, we would at least want to have done all this. Like we would have at least want to seen this baby and this parent together. Yeah. But I typically have not used them that way. I don't think that's their primary intent, these types of tools. Whereas I think a lot of times parenting assessments can be fairly cut and dry that way, and that's what judges may be looking for or whatnot. So, let me throw up these links and resources. The Infant Institute is where these, the working model and the Kroll were developed out of. They've got lots of great information on their website about the training for those and just infant mental health in general. Great resource, 0 to 3, the World Association of Infant Mental Health. There's a couple books that have great information about these types of assessments. Any final questions?
I have a question. So, when we did our CPP Learning Collaborative,
Yeah.
We were trying to work with the managed care companies to get reimbursed. We'll have to do diagnoses
Yeah.
for that. So how
Yeah.
does that fit? I mean, what would we be doing differently than this in order to come to a diagnosis for kids that were to get CPP?
Yeah, so that's a good question. My first thought is you could probably slap together a diagnosis from that initial interview where you go over kind of in the more traditional mental health evaluation kind of way, kind of what the child's behaviors are, what their development has, looked like, and you could come up with a developmentally appropriate diagnosis from the information you gather in that initial interview. The point I think I was trying to make is that more like the working model and the Kroll, that kind of protocol doesn't lend diagnostic information really in terms of the DSM kind of diagnostic information.
Helps with conceptualization.
Exactly. Yep. Exactly. That's a great way to think about it. It helps you conceptualize. But I think if you've done a good initial interview, you could probably get the information you needed for a code. Yeah.
What codes would you use? What would you use for a 2 or 3-year-old?
Yeah, so that's a huge question. Yeah, so there is a whole diagnostic, there's a whole diagnostic system for children age 0 to 5 out there called DC 0 to 5. Those codes aren't reimbursable in Tennessee at this point, as far as I know. But that might be a resource for helping you. There are crosswalks, so looking at the DC 0 to 5 disorders. You can buy the manual. It's from 0 to 3. You can buy it online. You can look at those disorders, and there are crosswalks for what those disorders kind of equate to in terms of a DSM diagnosis. And some of them are very intuitive. Like they have, I don't know what they call their PTSD, but it's obviously PTSD. Do they call it PTSD? Yeah. So you don't even necessarily need the crosswalk, I think. From a lot of them, it's fairly intuitive, the parallel. But I mean, I think you can, there are, I think there's latitude for adjustment disorders. If you're thinking DSM, I think that's probably maybe the most common. I have mixed feelings about something like a disruptive behavior disorder. I think you could easily do that, but for conceptualization purposes, I wouldn't find that a helpful diagnosis.
Can I add something?
Yeah.
We had a clinic at the University of Michigan doing these very assessments and billing for it, and oftentimes what we were getting was either trauma or anxiety, because the dysregulated behavior could often be conceptualized on
Yeah.
those two categories as developmentally appropriate manifestations of
Yeah.
those things.
Good. Yeah. Anxiety. That's a good one. That's a good point.
I've seen some people recently putting, even in their diagnostic impressions, putting diagnoses that aren't in the DSM, and then also including diagnoses. So maybe like a disruptive behavior, parent-child relational, but then
V code. Mm-hmm.
Yeah, those codes, but then also having like attachment disorder in there, and then explaining it further in the summary, I guess. That although that's not a DSM diagnosis,
Yeah.
it's capture a lot of what's going on or something.
Yeah. I think as long as that's kind of fleshed out and explained like what that means clinically.
DC 0 to 5 is though? Is that like a way of?
DC 0 to 5 does have a relationship, an axis where you can rate a relationship and essentially diagnose. I don't like thinking of it that way, but kind of evaluating and quantifying where you think the relationship functioning is.
So like for insurance purposes, you can't get reimbursed for that yet. I mean, you can't bill for that.
Right.
But is that standard practice or like normal practice for assessors?
In the places where I've been, where there's an infant mental health awareness and community, we absolutely use DC 0 to 5. Yeah. And so it's definitely the standard for, infant mental health trained folks or, folks who are wanting to do infant mental health work. Yeah. And I've been advocating with Michelle to get someone out here to do DC, and I know Mindy too has been advocating to get some DC 0 to 5 training.
Reimbursement for the assessments themselves, would you bill under like a psychotherapy code?
That's a great question. What you have a thought, Mindy?
When we talk
Sorry.
about CPP, I find that it's the assessment phase has been renamed to the foundational phase.
Yeah.
With the recognition that a lot of assessment is also treatment.
Yeah.
So some of it's assessment, but some of it is also you can bill a 90847.
Yeah. Especially with these methods, like I say, when you're videotaping them and you're doing video feedback, I mean, that's a therapeutic process. So I think a lot of this type of assessment has a more therapeutic.
If there's a lot of work afterwards, though, and reviewing the videotape and writing it up, you wouldn't be able to bill for that, though, I guess.
Like the writing up of the report.
Yeah, okay.
Yeah. I don't know how to get. What's that?
In Michigan, we were able to add an interactive complexity code to the assessment, which we billed for as an outpatient evaluation, like first-time assessment. We also had a psychiatrist behind the mirror, so we got that integrated medicine. But for the behavioral ops piece, we were able to get interactive complexity.
Which is minimal over the very.
Right. Yes. No, I know.
It's
We weren't
nearly
making
enough.
money off of that in
Yeah.
any way.
Yeah.
But we also had a training component that they were able to justify that they were training folks in this assessment method.
So with the pilot in
Yeah.
Davidson County,
Yeah.
covering the cost of this.
Well, I'm the only person in Davidson County who does these, I think, or who knows how to do these. I think. I don't know. Maybe there's someone I haven't met, but so we're not doing it yet. Yeah.
But with our new pilot projects, we will have to wait to do that, maybe.
Well, do you want to be on the task force? Because on July 28th, we're having a meeting, really to do like a stakeholder meeting and get the MCOs and you all. I haven't invited you yet, but everybody there, because this is going to be the problem. As we try to bring CPP, we've got to simultaneously work on how to do this so people can do their training cases. So it's big, and we the proverbial, aim high TN, we tried a couple of years ago to engage the MCOs, and basically, they said, well, show us where we denied it. And, it's like, so it was an impossible conversation, but I think this timing might be right to have the conversation again, but it's going to take some real system move.
So, thinking about defending a PTSD diagnosis in a, 9-month-old,
Oh, you
the
can
MCO
defend
audit,
it.
so.
Because a PTSD, they have, that's defensible because they have symptoms that are identifiable. So that one's easy.
Well, we're generating a lot of enthusiasm, I think.
Yeah.
But we're also generating a lot of challenges, so.
Yes.
We are absolutely interested in doing a new task force, Michelle.
July 28th.
Well, tell me this, Giovanni. If you were in charge for this evaluation, just saying.
You're putting me on the spot. I don't even know. I've never done it in that capacity where I was like in a practice or anything. Mindy, you're in private practice. What do you do?
If I were in private practice, half the time I would get paid for what I do. But I do an intake. I charge as part of the intake. And then,
Wait, how long? I mean,
it's a 907, 901,
Yeah,
one of those. And then, but like I said, for the role and for the working model, I count those as treatment sessions because I'm including treatment into that.
all right. Just thinking out loud. But say you did want to just charge a flat rate. like you're talking about. Okay, let me ask you this. Are you saying that what TennCare pays for reimbursement for a 90801 and then 2 sessions would be adequate to cover?
No. Catherine Shea, there's a really, I can get it to you, send it out. Catherine Shea in Florida has written a whole thing on Medicaid paying for infant mental health.
Right.
And you know that, is it Arkansas or Alabama. One of those just got infant mental health and 10 care. A lot of states are working on it right now.
There's actually a work group, so Aim High TN is part of the alliance, that's how we're getting the endorsement, and so that's like 27 or 29 states. And so there is actually a work group at the national level around that, and all connected together to try to, use their same problem-solving strategies. And so it's not like other places have it totally figured out. I mean, it really is a work in progress. And one of those things, we got to do it as we're doing, building the budget as you're writing it.
Yeah.
We can't get it solved until we're trying to do it. So
Another-
Yeah, go ahead. I think that, so a lot of places that do this are partially grant funded. I'm also thinking of that Senior Leader Summit where you bring stakeholders, including the insurance companies, and really have them buy in as we're.
That's what we're doing on July 28th.
Well, so I guess what I'm really asking, just like, forget even reading between the lines, if, for instance, DCS were going to flat out pay for it, just say, just tell me what ballpark we're in. And remember that everything goes to the lowest bidder.
I mean, I've charged it for the assessment.
Yeah, just the assessment.
Just the assessment.
Just the assessment.
It's going to be a couple thousand.
No, you gotta get lower. All right.
But some of that would be, I'd say 2,000 would be a ballpark of how long it takes. But we can also get lower. I mean, I rarely get paid that.
I was thinking more like just saying like, I don't know, 300 or something. I mean, like, what can you do for that?
The $600 that DCS pays for preparing the assessment.
Yeah.
It's not, but that doesn't make sense.
Can you do anything for that? Okay. I just mean how.
Negotiating.
I see that getting the guidelines rewritten takes years for how we pay for what we pay
It
for.
doesn't matter. We rewrote them and they still don't do them, but.
And there is that, but you can't even start without the guidelines. So I'm just wondering for that break, like what we could do, because I'm thinking that because Aaron and I are talking, all you really have to do is get it under a category that exists. First place, find a category that already exists, and then just go to a provider and say, listen, fit it in this category, what can you do? Here's about what we pay, what can you do?
Lisa, Lisa had a
Well, I just think it's
point?
interesting. Michelle and I talked a couple of weeks ago about that. There are standards for a clinical parenting assessment. And what we were doing for $675 was an addiction severity index, a clinical interview with an LCSW with diagnosis if applicable, 2 observations with a PhD in early childhood with parent-child interaction, the AAPI, an IQ test to factor in all those things, and they came back to us and said, we have someone who will do a minimal version of what you're doing for $300. We will no longer use you.
That's why you
unless
need
you do it for
somebody
$3.
to
And we're like,
and they have to use the lowest bidder, but then you have to move back in and justify. You have to have somebody to move back in and say, here's my written justification. That would be like me, not for you, but say somebody like me would say, here's my justification for why we're not using the lowest bidder. Like I just did this on psychological. It's like because our lowest bidder can't turn the reports around. It's taken 4 months to. That's not even really the reason that it works.
It works.
That's a reason.
We're not doing it for that.
Well, you don't. You got
not
to
fair to
justify
the
your rent.
family.
Yeah, you're right. You're right.
Yeah.
Somebody else can have it.
We should talk.
They have it for $300.
Well, somebody else gets it, and then you don't get the quality. Then we don't get the quality product.
absolutely.
Yeah.
Well, I'm glad this conversation is coming up because it was bound to at some point during the day, as we were talking about all these a whole new population, and a whole new set of clinical methods and approaches. So I'm sure you all can continue the conversation throughout the afternoon. I'm trying to get you that long lunch.
So you all have a thing in your packet if you're not from around here.